everyone. Welcome to our 36th and final webinar for the year 2022. I'm Niti Dasturi here on behalf of the Circle of Cleft Professionals. Today's webinar is a very interesting one where we will get to discuss the strengths and challenges when developing and sustaining team-based cleft care and holistic patient management within LMIC context. As always, we will be having simultaneous interpretation in Spanish by Ben and Eva from Chile for the entire duration of this webinar. At the bottom of your screen, you will see an interpretation button. If you would like to hear the rest of this webinar in Spanish, please click on that button and select Spanish. If your bandwidth allows, please keep your video on. It would be lovely if you could introduce yourself to the group and tell us where you're from while also displaying your full name on your Zoom screen. At any point during the presentation or discussion, feel free to type in your questions or comments or to use Zoom reactions. Please do keep yourself muted when not addressing the group. Finally, or when we open for discussion, feel free to share your thoughts either via chat or on video by raising your hand. This is how our webinar will flow today. We will begin with a quick COCP update, followed by a presentation for the first half hour by Dr. Solomon Obiri-Yeboah from Ghana. Post that, we will open for discussion with questions and so on for the remaining half hour. We have three core objectives at the COCP. Our aim is to facilitate networking and collaboration amongst cleft professionals, to communicate the learning and impact that's happening within cleft care, and to support the growth of local teams in implementing comprehensive care. Our members are spread across the globe. We are now a network of over 700 cleft professionals from over 80 countries and multiple specialties. As you can see here, the COCP represents professionals from a wide range of specialties within cleft care, including surgeons and speech therapists who make up half of the COCP, but also nutritionists, social workers, psychologists, orthodontics, nurses, and so on, all of the specialists and disciplines that make up a cleft care team. A shout out to these 11 international charity organizations, all of who have come together to make the COCP and all of its activities possible. Over to you, Hugh.
Thanks, Niti. Again, my name is Hugh Brewster. I'm delighted you've joined us for this last webinar of 2022. It's a topic that's very close to my heart as I was thinking about this new phase of comprehensive cleft care where there's a lot more funding than there used to be for multiple disciplines, as we saw back to the slide that Niti showed. Even among this circle, we have surgeons and speech therapists and orthodontists and dentists, but also psychologists, social workers. I mean, this whole idea of people who are very committed in their hearts to making sure that children and families make a full rehabilitation from their cleft. But then the question is, how do we work together? It's not enough just to have an extra silo that gets added in, that sense of working together, maximizing the strengths of each person's discipline, and then bringing that together to really think about results and how we move forward is critical to our work together. So I am so delighted to have been sitting next to in Edinburgh the very first time I met Dr. Solomon, although he has some history with Transforming Faces way back. I was delighted to spend some time over dinner chatting and understanding that, this is someone who is an expert in this topic. And I was able to sit in on his presentation at Cleft 2022 and was really inspired. So, that, as you say here on this overview, the global consensus is clear that this team-based CLP care is the gold standard. And Dr. Solomon feels this very closely. He wants to grow in this way, as all of us do in this journey. And we're delighted to have him here today. He's a senior lecturer with the Nuss School of Medicine and Dentistry. He's a senior specialist oral and maxillofacial surgeon at Komfo Anoike Teaching Hospital in Ghana. And he's a board member and lead surgeon for the Ghana Cleft Foundation and Ghana team leader for PACT. Lots of stuff he's up to. He's bringing expertise from all those quarters in today. So without further ado, I'm going to pass the mic over to Dr. Solomon to take us through a discussion. As always, we'll hear from him. If you have comments or questions along the way, please use the chat button. And then we'll spend a good amount of time talking about how this works in all of our contexts and then quizzing Dr. Solomon a little bit more about how to take this deeper. If you missed the beginning, please do introduce yourself on the chat. Let us know who you are and where you're calling in from so that we can really understand each one of our comments and questions along the way. Dr. Solomon.
Yes. Thank you very much, Hugh, for the opportunity to share with the audience.
Perfect. Yes, and we see your screen. It's beautiful.
So now that's my screen. I hope everybody can see. Thank you very much. I've been introduced already, and for that matter, I don't need to talk much about myself. We are going to look at this topic under the various outline. Just a little bit of introduction. We know that these children born with clefts have all sorts of issues, which include aesthetics, psychosocial feeding, general medical and infections, speech, and even growth. And because of this, their assessments need a comprehensive assessment. And they need to go through all sorts of things, issues to get the care, the kind of care they need. Sometimes they need to miss schools. Their parents need to miss work and other things to attend some appointment and all that. And to cut all these things short and to help them, then there's the need for team care, which will actually provide a comprehensive care for them and also reduce their burden in visiting so many people. Some of the challenges of these children include access to care in Africa. Access to care is a big problem. And apart from access, there's the issue of medical problems. There's an issue of feeding, speech. There's an issue of psychosocial issues. In Africa, there's a big problem, even to the extent that some families are extracized because they have a child with cleft. Some children are thrown away into the rivers because they think that they are river gods, and all sort of issues concerning children born with cleft and other deformities. Again, when they even leave, they have issues with dental and other issues, and all these problems need to be looked at. So I looked at the ACPA definition for team and what ACPA means when they talk about team. So this is a quote from ACPA's website. It said a team comprised of experienced and qualified professionals from medical, surgical, dental, and allied health disciplines working in an interdisciplinary coordinated system. And the purpose and goal of team is to ensure that care is provided in coordinated and consistent manner with the proper sequencing of evaluation and treatment within the framework of the patient's overall development, medical and psychological needs. Most of the time when we talk about team care, we look at the professionals. We don't add the patient or the child or the parent or the family. And I think that whatever team we create, the center is the parent. The center is the child with a cleft. The center is a family with that child born with cleft. So because we all will meet, without the child, our meeting will not be of anything. You can, as a doctor, as multidisciplinary care team, you can ask the parent to bring the child for review in 2 weeks, in 1 month, in 3 months. If the parent doesn't come, there's no meeting and there's no care for the child. So we believe, or I believe, that the patient is a center for all team care, and that needs to be taken care of. There has been 2 approaches to team care. The first one, which is the conveyor belt kind of team care, where disciplines, specialties stay in their offices, comfort areas, and the patient is being passed on from one office to another office to another office to receive care. So as a surgeon, I see the patient, and then I book appointment with the patient with a pediatrician, on a different day or even the same day, but the patient has to walk to the pediatrician's office and all that, and the patient has to move from one place to another, which I believe is not the ideal way of team care. Even though from time to time, such people meet together and discuss difficult cases. The ideal one is when we all meet at one place, and then with the common goal, we have discussions for the kind of patient that we have in front of us, discuss, and that also helps us to learn from each other. As a surgeon, I will learn from the pediatrician. As a surgeon, I will learn from how the speech language pathologists assess speech, and that will help me when I'm even doing my surgery. So when we come together, we learn from each other and also get to understand what the patient's need is. I listed this limitations of team formation or team care in what we have in Africa in our setting. Most programs basically focus on surgical corrections. And we don't have funding, and the funding we have are most of the time based on surgical care. As even because everything is based on surgery, most of the teams in Africa has evolved largely out of surgical services, and most of the leaders in African teams are surgeons. And whatever team we have around is based on availability of our expertise. And because of this, our partnership with partners in African Cleft Training, which is from Seattle and some 5 African countries, Ghana, Nigeria, Liberia, Ethiopia, and Kenya, that we come together from time to time to look at building teams, how to build teams. We had a project and had a survey to look at challenges to developing and sustaining cleft team care in Africa. And out of the project, we came out with these 5 themes to look at. And we did not just look at the challenges, we also looked at solutions to be able to overcome these challenges. And we'll look at this one after the other. The first one is lack of awareness of team care concept. In Africa and within our sub-region, West African sub-region, there's limitation of understanding of the value of the multidisciplinary team care. A lot of people do not understand the value of team care. Also, there's lack of standardized care protocol in use in Africa. A lot of people don't use any protocols, and they just go in and do surgeries. And most of our cleft care is NGO sponsored. And most of these NGOs emphasize on numbers because they need the numbers to get their donors to donate to them. And because of this pressure, that pressure comes to us to produce the numbers. And when I'm talking about numbers, it's about surgery done. How many cases have you done? How many cases have you been able to do for the year? The concentration is not more on the team care. It rather pushes us who are being sponsored or being funded by these NGOs to concentrate on surgeries more than team care for these children. And even the few teams that have been formed, there's a problem of communication among members. And then we came out with certain solutions that can help us overcome these. And we think that increasing education about team care for providers, hospital administrators, policymakers, and NGOs will help. And also develop and promote protocols to guide our team care in Africa. And also support and disseminate collaborative research about outcomes with team care. And all this will help us achieve our target. The third point we looked at is insufficient trained providers. There's a lack of trained providers for clefts, especially in the area of speech and speech language pathology and orthodontist. There are lack of these specialties in our region. So we don't have enough, and therefore the need for team coordinators. A lot of teams don't have coordinators. The surgeon is the leader, the coordinator, and everything. And sometimes they become so overwhelmed, and people get tired and stop coming to meetings. Providers need to assess continuing education for retention. And some of the solutions that we came out with to be able to identify and support training for disciplines. So if in my team we lack some kind of discipline or specialty, we try to rally support so that that person can go and have some training and come and support the team. Improve incentive for dedicated time with Cleft team. Unlike the Western part in America, Europe, my experience with these teams in America and Europe is such that they have the cleft and craniofacial department or unit who everybody working within that department or that unit is salary based. I mean, he's been employed to provide that particular care to the team. Unfortunately, in Africa, it's not like that. We have been employed. I've been employed as a maxillofacial surgeon in my hospital and in my university to teach. And going to cleft clinic or providing my service to cleft patients is extra, is secondary. And for that matter, if there's no passion for it and there's nothing pushing me to do it, I would rather prefer to stay behind and do the job I've been called to pay for. Secondly, sometimes certain administrators, if you leave your job, what you are being paid for, to these meetings, they think that you are wasting your time because that's not what you have been paid to do. So that's some of the issues that come. So if we're able to get some salary-based structure for these specialties, it will help us. Again, there's lack of educational resources and opportunities. And we realize that there's limited educational resources for patients, even families. They come to clinic, they have nothing to look at, there's nothing going on, and for them to know what is even happening to them. And sometimes there's not even enough contact with the providers to educate them on what their children have and all that. So we came out with the solution that there should be some educational, continuing education for all disciplines. And therefore we need to have some cleft conferences. Our PACT, which we have workshops every 3 months, every quarter of the year. And once every year we come together at one point and have hands-on and other things is helping. Videos online, and then all this will improve our knowledge. Last but not the least is inadequate infrastructure, which actually complicates care. There's lack of facilities. We don't have enough equipment. Sometimes if you go to certain places to do surgery and you realize that the kind of scissor they are using is what they are using for abdominal surgeries, it's really very uncomfortable. And for that matter, what kind of surgery are they doing? So lack of equipment. We don't have clinic spaces for our meetings. Operating theaters are very limited. Sometimes some places they have only 2 theaters. That's the same place they are using for gynecological cases, general surgical cases, and for that matter, if you want to go and do cleft there, it's like you are taking the bulk, what brings bulk of money to the hospital, and managers will not allow that. So we have all these challenges. The picture below is one of our clinics. We are using 2 dental surgical suits dental surgical rooms to do our clinic. And this is one of them. You can see the number of people that are crowded over one patient. Space is actually a problem. And I believe with the help of SmileTrain, we are putting up a big complex that very soon this will be a thing of the past. And with this, our collaboration with our NGOs and other people will help us overcome some of these challenges. Funding constraints is one of the issues. Like I said before, most of the funding comes from NGOs, and that is what has actually skewed our concentration to surgery. And therefore, there's the need to lobby governments and hospital to help fund these projects. And also, we need to have local NGOs so that local people who have can also donate into these NGOs. Like we have Ghana Cleft Foundation, where other people from willingly donate into it for us to support other aspects of care for our patients. So there's a need for this to be established. Resources for traveling and care. I think it's time for us to move from charity-based care towards institutionally supported care, where our collaborators, our sponsors, our friends from the West, from the East, come with everything they need. They come with everything they need, sometimes even including water they will drink. They come with everything. They come and do surgeries and pack their things and go back. And patient born with clefts sometimes needs to wait for one year, 2 years. I think if you have not learned anything, COVID has come to teach us that you cannot be there for us all the time. And the best way to help us is to teach us, help us to take care of our own. I think this is what we should be focusing on now, that there's the need for you to bring what you have to support us, to train us, equip us so that we can take care of our own people when you have not the means to come. So we also need to appeal for Cleft Care to fall under national health insurance, because in Ghana, for instance, Cleft is not under the national health insurance, and therefore parents need to pay for it. And if they don't have money, then that is a problem. That's why the NGOs are helping us to do this. The example of multidisciplinary Cleft Care in Kumasi, as I said, our center started in 2003 when my boss, Professor Peter Donko, started this with 3 other plastic surgeons, nurses, some few nurses, and an orthodontist. Along the line, in 2007, we had support from from SmileTrain, and we also created our Ghana Cleft Foundation, the local foundation, to support the multidisciplinary team. In our team, we have a pediatrician, we have a nutritionist, we have a speech language therapist, we have an orthodontist, we have currently we added on a pediatric dentist, and we have nurses who is a nurse who is a coordinator, and we have nurses who are also supporting our surgical colleagues, oral and maxillofacial surgeons. We have plastic surgeons and ENT, and even a neurosurgeon on the team. We have a social worker who brought a lot of dynamics into our team. We will look at briefly. And we have a health educationist, a geneticist, and a data manager. And I've brought in the parent support group because they are the center of our care. And they bring our parents together, help them, educate them, and let them feel that they are also important. And to ensure continuity and to ensure harmony in team care, what we do is that we define our roles very well. Everybody knows what he's doing. We respect each other. It doesn't matter who you are in the team. There's maximum respect. The team leader is fair and recognized by all, even including families, how we even relate to the families. When you come and you are talking to families, you feel like, oh, they also feel part of the management, and that helps them and to be coming all the time. Sometimes there need to be settlement of certain issues within the team, and conflict of surgical disciplines. The maxillofacial surgeon says, I'm the boss. The plastic surgeon says, I am the one who's supposed to do this. We try as much as possible not to bring those kind of rough amongst us. We try to settle all these things and everybody be in his lane and do what he's supposed to do. The emphasis is quality of care that needs to be provided for the patient. And that is what we always emphasize on. We need also to provide, when the patient comes for the first time, there's the need to give the mother, the parents, whoever brought the child, the maximum, all the information they need to know about the child. So we need to tell them what they have to go through before surgery and after surgery, what they need to do and all that. And this helps them to come back for review and to come back for review and provide. Also, we need to meet regularly to provide feedback and all that. It's also very important that we bear the responsibilities for uptake of treatment as a leader who is leading the team. So this is the beginning of the Ghana Cleft multidisciplinary team. You can see the young professor. Then he was very young. Now is Professor Peter Donko, who started the team. Dr. Adu, Professor Abonoku. Adu and Abonoku are plastic surgeons. The speech and language pathologist is there, Mr. Bejina, and these nurses coordinators, and Dr. Mrs. Plandrew, who is our pediatrician and with the team, and then Dr. Ansan, who was a resident then, and a nurse who was also assisting. So this was the team, and now the team have grown. We had a social worker, workers, 2 of them, who now we started home visits. So now we're now following our patients to their houses to know what they are going through and what is happening, and let them feel that they are part of us. And every year, at the beginning of the year, we have party for all these children and their parents. And they come together, they dance. And for all you know, for a child born with cleft, this is the first within the year to have this kind of fun, to go to a place like this, to eat and to drink and to enjoy themselves. And we don't leave them alone to do that. We enjoy with them. You can see our pediatrician dancing with them. I have other pictures that I did not put in, where Professor Peter Donko and his wife were dancing with them. And even the parents also get their share. So it brings the parents together during this kind of time. So how we have grown our team is that we have put emphasis on succession plan for leadership. And therefore, it started with Professor Peter Donko. He has trained me, and I'm training other people to take over from me. And the same thing is going on and going and going. So from time to time, we have people coming up, and our team keeps on increasing and increasing. So there's emphasis on training the next generation of specialties, regular team meetings, expanding infrastructure, research, international partnership. We need you as well to also support us, and building of a center of excellence. All these are very important things that we need to look at in building a team. This is to show our partners so far. We have PACT with Seattle Children, where we come together and train ourselves on team building, and also provide skills, surgery, anesthesia, speech. Out of this, a lot of things has happened. We have developed speech language therapies. We have developed people giving skills to a lot of surgeons to provide surgery. And our big sponsors, Smile Train, who has been supporting us since and even giving us a very nice edifice to provide care and training and research for parents, children born with cleft, and other surgeons and providers. And then our collaboration with Children's of Alabama on the aspect of craniofacial surgery, equipment, training skills to provide complex surgical treatment and other treatment for our patients. And the bottom one is telling you that our arms are still open. The circle is not complete. We still need more collaborations. We still need more people to come and support and assist. So anyone who want to come and assist and help us develop more and further is welcome. So in conclusion, we are saying that Cleft Craniofacial Team is a means of organizing complex multi-specialty care in a humane and cost-effective manner. The team approach reduces cost, minimize school and work time loss, and promote a more comprehensive view of care. It implies quality peer review on continuous basis, and constructing the most effective team possible is a challenge. There's no two ways about that. But the reward lies in the shared group interactions, the bonding, and the satisfaction families and patients have. So identifying barriers and working towards solutions is a sure way to improve cleft care for our children. And ending, I want to let you know that every cleft child is first a child and not a cleft. We should not see them as cleft. And that's what surgeons see. Surgeons see cleft, they don't see children. And therefore, once they see cleft, they want to rush and go and do it. Please see them as children, as humans, and not tools or objects to operate on. With this, we'll be able to understand that they need all of us to come together to provide care for them. With this, I say that thank you. The mother says thank you. Father says we really appreciate it. And the baby yet to be born with clefts this year. A lot. Thank you very much.
Fantastic. Thank you, Dr. Solomon. You've left us with a lot to talk about. Lots of very bold statements that I would love to hear from this group about what resonates, what further questions that they have. And actually, Dr. Solomon, if you could go back to your slide about the 5 key challenges, I think that would be a good place for us to start, and then we'll stop sharing your screen in a second. But I think my first question for the group, and either you may use the chat or else you may signal, and it'd be great to hear your voice also if you have a question or comment. But my first question to the group is, what do you think about these 5 key barriers that Dr. Solomon's research through PACT has uncovered? Which are most prevalent in your own context, and which do you think are the biggest priority to start addressing? And Dr. Solomon has led us through a very thoughtful exposition of some of the ways to do this. But let's start from the group. What really stands out for you about these 5 barriers, and where do you think is a priority in your context that would allow you to move forward in this team-based care that Dr. Solomon has so eloquently exposed today? And again, please feel free, if you haven't yet, you may use the chat to introduce yourself or signal that you'd like to ask a question. Suraj, you've kicked us off here, but how do what do you see in your own context? What is a priority for you in terms of moving forward in this team-based care?
Thank you, Hugh. Thank you, Dr. Solomon, for such an interesting presentation. These are known facts, but to hear and then resonate, it is very important to do that. And I think all these factors are interlinked. It is very difficult to plug one out of it and then see what takes more priority, because if you take any puzzle, it is like creating a cleft, and the treatment team will get paralyzed. That's what I have seen, because if you don't have funding, you cannot train people. If you cannot train people, it will lead to limited access to care. So this is a process, you really don't know. And some of the organizations have invested in, local teams. As an institution like Transforming Faces Smile Training, you all should be able to see how continuous training, continuous support has evolved in sustaining cleft care in low and middle income countries. So I think in my perspective, it is very difficult to see these 5 most important factors independently.
Thank you, Suraj. Dr. Solomon, you point to the beginning of saying, well, if we don't understand that there's a problem with these different silos, then it's really hard to move forward. What do you feel like was the biggest, the most successful way of developing, probably along with your mentor, Professor Peter Doncourt, but what moved you forward in terms of understanding this idea that the team-based concept actually would be, as you mentioned in your overview, the gold standard?
Right. I want to give the opportunity for my boss to answer this question, if you wish.
Are you there, Professor Doncourt? Would you like to jump in? What helped you move that forward in terms of building that awareness that a team-based care could be a way forward that would be to lead to better results for children and families?
Well, I would say that, thank you very much. And Solomon, that was a fantastic presentation. Well done.
Thank you.
Well, let me say that I think when we started our clinic, we realized, I mean, let's say when I started operating on these children with cleft, it became very obvious that many of the children were very deprived, and they traveled from very far away to come and see us. And we needed, after one practitioner had seen them, they needed to go and see other practitioners. So we thought, well, wouldn't it be good if we could all come together and see them in one location and limit the number of trips they needed to make, because when one trip was so expensive for them, they could not afford it. So we just have to speak with individuals who were seeing them and say, why don't we come together? And they all agreed to come together. So that was the first step. But as Solomon mentioned, it was individuals who were willing to volunteer their time, who were committed to improving things for these very deprived children. From that point on, we needed to innovate. Some people had to double up as nutritionists, even though we didn't have a nutritionist. Others had to work and do more tasks until we got a specialist, and then we looked for opportunities to train people. But you have to start somewhere with a small group and then build on it bit by bit. But it starts with having people who are committed to do it. It's a small group of people and adding to that number. Thank you.
Lovely. So that idea in your own context for all of us around the world, thinking, who is your core? As Professor Peter and Dr. Solomon have talked about, how do you start from those core of committed people and then build out in terms of that awareness? And we'll hear from Dr. Edwin in a second. Dr. Solomon, the other thing that really stood out for me about this part was, we're so used to designing our systems about who sees when, as Professor Peter was talking about, around our own convenience. Like what's the best for my schedule? Your positioning and your challenge to us is thinking, well, what makes it easiest for our patients and families? And especially in light of what Professor Peter was talking about, these long distances and the expense and the danger of travel. What was that process like of thinking about children at the center and then designing your systems around that? Can you say some more about that?
Yes. So like Professor Peter Doncourt said, our main focus is providing comprehensive care for the child, and also interested in what the parent goes through. So looking at they coming to the clinic, and sometimes even when they come to the hospital, they don't know where to go. It's a big hospital. They come, they move from places to places. Before they get to the clinic, they're already exhausted. And then you see the patient and tell the patient, okay, I've finished seeing you, go and see the pediatrician in another place. He has to walk again. And looking at all this, you realize that it is not the best way to take care of these patients. First of all, their time, their money, sometimes they have to go and come back. All this is transportation, the risk in transporting yourself in Ghana and all that. So why not bring all these specialties together at one point? And when the patient comes, we all meet and see this patient. And I think that is what brought the team care. And we've also
Well, I think we've lost Dr. Solomon for 1 second. I think we got the majority that we'll hear from Dr. Edwin, and then hopefully Dr. Solomon his internet will come back. Edwin, please go ahead.
Okay, thank you. Can you hear me?
We can. Yes.
Okay. Thank you, Dr. Solomon, because basically what you said mirrors more closely our situation here in Asia, at least in the middle and low-income countries. First of all, the health system, our government health system does not really support that much or put more emphasis on healthcare, on cleft care, because the priorities are different. In countries like ours, infectious diseases and etc. are of a greater concern than cleft care. So it is a small priority in the context of the healthcare system here. And so much of this work is being done by the NGOs. And the NGOs are dependent on funding. And the NGOs are dependent on volunteerism. And as you know, sustainability is not very good for when you're talking of volunteerism. At some point, they get tired. At some point, they have to move on because they have to earn something, to earn living. So they move on. While initially they may be very enthusiastic about volunteering for things like this, they have to move on to earn a living. And so, as Suraj has said, they are all interrelated. And the question really is, where do you start? Where do you actually start? And how, when you start the ball rolling, how do you maintain this? Funding sources, of course, is very important here. But then at the current moment, the funding sources are also focused on surgical outcomes, as Dr. Solomon has said. They're more focused on surgical outcomes, and they want to get the number. And this, again, does not bode well with teamwork, because you need funding also for speech therapy, for orthodontics. You need funding for the other members of the team, but you just get funding for surgical treatment. So that is why in countries like ours, the medical mission model is very popular. Institutionalized training is difficult to encourage because of the lack of funding support as well. So
thank you,
the
Dr.
question really is, where do we start? Where do we start?
Yeah, no, lovely context. I think we've heard from Dr. Solomon about where they started in Ghana under the leadership of Professor Donkor. But yeah, you're talking about a bunch, and I've put in the chat some of these key elements. You know, volunteers. How do we have this conversation?
Not again.
I think we've lost Hugh for a minute. I'm sure he'll be coming back soon.
Niti, while there's a pause, can I say a couple of words?
Of course.
First of all, congratulations to Dr. Solomon. What a beautiful presentation. And what a wonderful, wonderful concept of how their center has grown from nothing to what it is today. And to acknowledge Peter is wonderful. And what I really think is that the leadership at the top is really what is absolutely essential to start a program such as this. And to have a leader that is strong and understanding and collaborative and gives respect, as Solomon said, to every member of the team is critical. So for any group that is looking towards starting a multidisciplinary team, the leader of the team must be a strong leader and must be very collaborative and willing to work with other people on an equal basis. And it doesn't matter what subspecialty that person is. It could be a surgeon, it could be a nurse, it could be a speech pathologist. It doesn't matter, but that person needs to be collaborative and give each individual his rightful say. So Solomon, thank you very much for putting that all together and for saying it so beautifully. Can I ask you a question with respect to maybe not cleft care, but craniofacial deformities and craniofacial anomalies? Are you able to accept people from a variety of different African countries to do this kind of work? Because so many are lacking in the expertise to look after these children. And with your multidisciplinary team and the craniofacial team that you've assembled, are you able to look after people from other parts of Africa?
Some great questions from Ron. Thank you. I think we might still be having some internet challenges to have Dr. Sullivan jump in. So we'll leave that question hanging. I know Michael's been waiting. Michael, please, what's your question or comment?
I'll say the answer to that question is yes.
Thank you.
The answer is yes. Thank you.
Very good. And thanks for jumping in, Professor Donkor.
Dr. Solomon, thank you so much for your keen insights into interdisciplinary care. We run a comprehensive cleft care center out of a mobile hospital in Oaxaca, Mexico, and have worked very hard to mirror what you've presented in your presentation today with a multidisciplinary team providing all aspects of care. I think the greatest challenge is to move from charity care to institutional support. And we are encouraged because I just got back from Mexico, having a meeting in Mexico City with a key person in the Federal Ministry of Health, and they visited our hospital and are well aware of Smile Train's partnerships throughout the country. And they have put together a task force to create a national health policy to elevate cleft lip and cleft palate care to a national health policy. And we're in the process of amassing materials, and I want to pose this to everybody on the call today. Are there countries who currently have a national health policy for cleft lip and cleft palate where the country has adopted this as a national priority?
Great question, Michael. And I can definitely name a few. I mean, maybe we can post that in the chat. I know, for example, Chile has had some victories, and some people on the call from Chile are aware of that move towards a national protocol, which might be applicable also in a Spanish-speaking country. But Dr. Solomon, also, you've mentioned this idea of that without a protocol, it's hard to know how to convince people, to move forward, that the sense of if the different professionals are not aware of what these timelines and how to work together, there's not some document bringing together, then it just falls down to personal conversations and a personal leader, as Dr. Ron has mentioned. Can you talk a little bit more about that? You mentioned that in your presentation, that idea of having a protocol and having something written down that can rally the team together.
Yes, all right. Thank you very much. I hope now you can hear me.
We can, yes.
All right. Yes, so for every team to thrive and to be sustained, there need to be some written down protocols. And for everybody in the team to know his or her role when he's in the team. And for most of the time, the rough is between the surgical disciplines. So if I'm a maxillofacial surgeon and there's a plastic surgeon, there should be that kind of relationship. Everybody knows what he's doing. We all come, we share ideas. We go and do. I mean, if you know how to do this, I know how to do that. we share ideas and bring them together. Secondly, there should be a written down protocol as to what, when the patient comes for the first day, what do we need to do? Who does the patient need to see? Who needs to see the patient first? And all that. I mean, that has to flow so that it won't be like I'm the one to see the patient first. He's the one to see the patient first. There should be that kind of coordination amongst the disciplines. And then there should be a written down protocol for the treatment guideline, when to do what, at what time should this discipline comes in. And then even after surgery, what is next? We need to spell out all these treatment plans with the patient and explain to them. So the mother knows that, well, when I come, as I bring my child, first day, baby is born. When I bring my child, when I come to the hospital, the patient comes because he wants to receive treatment. He wants the lip to close. He wants the palate to be closed. But he doesn't know about speech. He doesn't know about whatever is going on. We need to go through all these things with them. And I think these protocols need to be written down and everybody will follow it, so that when you are not even there, when I am not there, the one who is after me can follow the same protocol and provide the same quality of care to the patient. Thank you.
Thank you. Very good. And I see Carolina Caramaro also pointing to the National Cleft Care protocol in Argentina as another great example. Dr. Solomon, thank you for that. There's also a very interesting point that you mentioned, is how can we ensure that parents feel part of this protocol? You know, that they understand, you said from the very first day what's going on, the professionals understand, but you mentioned even how can we make it clear to parents that they have a stake in the management of the team, that they have input, that they're not just recipients, but they actually have some sort of engagement and reason to come back for the whole treatment plan. What were some breakthroughs that you found in really bringing out this idea that families should have a stake in their own child's care throughout that long journey?
Well, I would say that this begins from the first contact with the patient and the parents, the first contact. And what we have been doing, is that when I see the parent, I let them know that whatever will happen is dependent on him or her. For her to know that we are there to support, we are there to assist, but for the child to receive the best care, it depends on her or the parent, the support from the father, from the mother. And we try to explain the various treatment lines or schedules to them and tell you that, well, when your child is 3 months, when we have gone through all this and that, this is what we are going to do. And therefore, we expect you to support us, to help us, to give the best care to your child. And we let them know that they are so important in the treatment care. We actually try to talk to them and have that kind of relationship. We give our numbers to them so that they can call us at any point in time when they need us. And sometimes they even ask you questions that has nothing to do with the child. They bring questions from issues they are facing, and we need to tackle all these things, bring in other people to help them solve all these issues. And this actually helps them to feel that, yes, they are part of the whole management. Secondly, we also have the parent support group, where we bring the mothers and the parents, the guardians, from time to time, quarterly, and give them some teachings, let them feel that, and some of them come to share their own experience to encourage other people to follow the protocols that we give them. And like I said, we also have time together with them every end of the year for them to feel part of us and part of the whole show. And this is what we have been doing, I think is actually helping. And then the home visits as well. When we visit them at homes where they live, they realize that, oh, we care about them. We are interested in the care of their children, and not only their children, even themselves. There have been cases that we support them even to get some trade to support themselves. Yes.
Fantastic. Yes, and we saw in the chat Dr. Carolina from Argentina talking about the strong parent group. We heard earlier from Professor Yuri about the importance of having these kind of social / networking gatherings. That picture was beautiful from Professor Donkor about how that's happening in Ghana. Tell me a little bit more about home visits. Who goes on home visits? You know, you're a busy surgeon. Do you have time to go out to the village and meet with people? What do you mean? Come on.
Yeah, so like I said, our social worker, when they came in, brought a lot of dynamics to our team. They started the home visit. So our social worker with some nurses started going to homes. So most of the visit is done by the social worker and some nurses. Sometimes if we have time, we join them in some of the visits to just go and see and have fun with the children, sit with them and all that. So it was basically done by the social worker, and he brought that kind of aspect to our team.
Fantastic.
Yes.
And I just want to emphasize from personally, you know, we were in a new context where comprehensive cleft care in Africa was a new idea. But having, you know, every member of the team at least have that experience of going on a home visit, even if it's a regular job of the social worker or a psychologist or speech therapist, but having that sense of sitting and, as you mentioned, you know, observing, listening to parents can be so critical, both for the motivation because this is complicated, right? Working as a team is not easy. I mean, you've laid out a clear case, but this is not an easy thing to get everyone to continue to work this way.
Sure. Yeah, it's true. It has actually not been easy, but the good thing is that we respect each and everyone in the team. And every idea anybody brings, we try to support the idea as long as it's going to help us give the best care to the patient.
Fantastic.
Yes.
Well, Dr. Solomon, you have given us lots to think about. I'm so glad that this is going to be uploaded onto YouTube so that we can review it with our own teams, because you've given us a lot of challenges about how we think about our work with NGOs, about how we transition to from a charity-based model or a volunteer-based model. What's that journey in our own context to having institutional support, whether through the Ministry of Health or whatever. Even that idea of the nitty-gritty of how we work together with people and maintain that harmony, but also that motivation to work together. These are all real challenges that I think no matter where we find ourselves on this comprehensive cleft care journey, there is lots there of that insight and that pioneering work that you've done in Ghana that can inspire some good conversations. Niti, where do we go from here? We have 2 minutes left in our time, and we're so grateful for everyone for carving out a space to be part of this conversation.
Well, we do have an exciting announcement to make. Our next third annual virtual conference, Solutions for CCC, Propelling Learning Through Collaborative Research, will be on the 23rd of March, 2023, for which we will be opening for registration soon. So stay tuned. You will be hearing more from us on this.
Great. And some of the topics include some topics that Dr. Solomon talked about, parent-patient support groups, of how we measure our progress in an evidence-informed approach, and even how we weave in this idea of psychosocial care, whether you have a social worker like Dr. Solomon has or whether you don't. How do you weave this idea, this understanding of what the patient's experience or family's experience is through every member of the team? These are 3 topics that we'll really explore through this conference coming up, sponsored by the Circle of Cleft Professionals. Excellent. So as I mentioned, we will be uploading this to the YouTube. You can follow us there. If you have colleagues who want to get involved, we're always looking for new topics and dynamic topics like we found today, and some of this rooted in the thoughtful research of PACT and others. And like you can let us know here at info@cleftcircle.org if you have questions or suggestions for topics that we can capture in the new year. Thank you very much. If this is a time of holiday in your country, we wish you very well in the rush to the end of the calendar year. And really, we're grateful to this very dynamic group, and especially to Dr. Solomon today for leading us through this important topic.
Thank you very
everyone.
much.
Thank you, Dr. Solomon.
Thank you.
Thank you, everyone.